So, tricuspid valve. It has received a lot of attention anyway recently. It still has a lot of unanswered questions and a lot of surgeons' bias into what we could do for it and what we should do for it. And it is, in general, still has a lot of gray areas that we don't have the answer for it. Now, the decision process for intervening for any valve goes into a different areas that have to be determined before. First of all, you want to know when would you want to intervene with this valve, and when would it be detrimental to survival or to the functional class. The other question that you'd always is, would you be able to repair that valve or you need to replace it? What is the risk involved with doing such a procedure? And what are the results of the repair or the replacement that you would embark on? And what is the durability of what you do, whether that be a repair or a replacement? And what is the survival benefit if the indication was a survival detriment for the presence of that valve pathology? Are you actually achieving survival advantage with interfering? And also, if you are actually changing the functional class of those patients. So when you put all these things together, you start processing in your mind whether you would actually want to interfere with this valve or you would want to wait for it. Now, what is relevant to the tricuspid valve itself? We do have an issue with the tricuspid valve in particular because of the following reasons. First of all, it is not the primary indication for intervention in most of the cases because it follows what happens on the left-sided valves. Symptoms of left-sided valves appear earlier. So when there is a patient having combined mitral and tricuspid or aortic and tricuspid, the symptoms of the left-sided appear earlier rather than the tricuspid valves showing up earlier. So it comes as a bystander when you interfere with the left-sided valve. The symptoms are tolerated for a longer time than left-sided valves. So people they don't present earlier and they would tolerate the symptoms of the tricuspid regurg. There are no clear cutoff limits. We do have some guidelines, but it's not as clear as they are on the left-sided valves. And the repair techniques are not standardized like the mitral valve. The mitral valve, we know exactly how we do with it and how we handle it, and it's much better in terms of repairability and predictability of the repairability compared to the tricuspid valve. On the functional class and survival could be determined by the left-sided lesions because it's always an associated lesion. It's very difficult to tease out only whether the tricuspid valve is a detriment to survival or not. Having said that, it is important to I'll just share with you a couple of papers which look specifically at the tricuspid valve regurgitation and whether it does affect survival or not. This is looking at a preoperative tricuspid valve, which is more than 2+ in 624 patients. Only 125 received tricuspid repair and mitral replacement, and the 106 received mitral valve alone. So those have been left with a 2+ TR, and some of them have had either repair or replacement, and they followed them up. And the tricuspid valve repair presented, first of all, their TR exceeding 2+ at operation was associated with a 53% increase in late death. So it does have a survival disadvantage when you leave TR. Now, you may say that this may not have been the case if it was an isolated tricuspid regurg, but the problem is we cannot, and the numbers of isolated TR is very rare. This is another paper looking at risk factors for early mortality after valve surgery. They looked at 5,672 patients undergoing valve surgery from 128 European centers analyzed, and they found that tricuspid surgery was an independent predictor for early mortality. So it does actually affect survival, the presence of tricuspid regurgitation. Now, what are the options for surgery? Repair, the advantages, preservation of patient's own tissue, less incidence of thromboembolism and endocarditis, preservation of left ventricular function, and superior hemodynamics. Disadvantages, it obviously needs expertise in the repair, although it's not as complicated as it could be in the mitral side, and may not be as durable as mitral valve replacement. The replacement advantages, it's easy surgery, you just plug in a valve, readily available in different sizes and for different patients. And it has also a recent advantage, which also you could have a valve-in-valve in case that valve degenerates earlier than later. Disadvantages, the anticoagulation, degeneration, endocarditis, and thromboembolism. So if we look at what can affect the tricuspid valve, majority of the tricuspid valve regurgitation is functional, and it's secondary to what happens on the left-sided valves. The only 20% are either rheumatic, myxomatous, Epstein, and some other rare pathologies, but the majority are on the left, secondary to the left-sided valves, or pulmonary hypertension, or primary right ventricular dysfunction, or volume loading from different shunts. Rheumatic involvement of tricuspid valve, also direct involvement, is not common. It happens anywhere between 7 to 10% of all rheumatic activity on the left side. They do represent a problem because repair in these valves is not very fruitful, and failure of such repair comes on earlier than later. Even sometimes they present independently, while the left-sided valves have been fixed either with a replacement or with a repair. Now, looking at the annular morphology of the tricuspid valve, it is a saddle shape with highest points located in anterior-posterior orientation and lowest points in the medial-lateral orientation. So you would see that this is not a planar annulus. And what does actually happen to these dimensions in severe tricuspid regurg? The annulus becomes dilated, and you would look down at this, the dilatation comes out on this lateral area, and it bulges out. It becomes all more planar with a decreased high-low distance, and it also becomes more circular with a decreased ratio of mediolateral to anterior-posterior diameter. So there's a lot of dimension as well as plane changes when the tricuspid valve dilates and you get severe tricuspid regurgitation. So what are the options available for us for tricuspid repair? Either a stitch annuloplasty, which the classic one is a de Vega, which basically a suture around the annulus, sparing the area of the conduction system, or a lateral annuloplasty, what's called the bicuspidization, or the K-type of plasty, edge-to-edge, the Clover technique, and some other use of rings. And this is the Clover technique. This is basically like the Alfieri stitch for the mitral valve, but because the tricuspid has 3 leaflets, then it's actually a one suture, but it takes the 3 leaflets together. This is some of the types of specific rings that have been designed for tricuspid valve, and this area obviously is the conduction system where all tricuspid valve rings have to spare to avoid the heart block after surgery for the tricuspid valve. There are different types of rings, and I'm not sure there are one of them is majorly superior than the other, because I think failure of the tricuspid valve repair is not purely dependent on what is the type of ring has been seen. And it's very difficult to tease that out because of the different associated surgeries and valvular lesion which comes in with tricuspid valve. Now, you could use a simple pericardial strip anteriorly and posteriorly, and that would take care of also the dilated annulus. And there are some data which shows that they are as good as ring annuloplasty. So the repair is feasible in almost all cases in functional tricuspid regurgitation. But we do have a question of durability for those repairs, and I'll share with you some of the data. Now, which patient undergoes mitral valve surgery should also have a tricuspid repair? This is looking at meta-analysis, looking at 390 papers, and they came out with the conclusion that if we are operating on the left-sided valves and you have an annular dimension of the tricuspid valve of over 21 millimeter per meter square, or a measurement by echo of 3.5, and you could challenge this, most surgeons would go for 4 centimeters, or an intraoperative dimension between the anteroposterior diameter or the anterolateral diameter to more than 70, then there is an indication or the possibility of repair when you do the left-sided valves. So looking at these patients who've had a de Vega repair, this is 332 consecutive patients. Majority of them have had, they were rheumatic, although they were functional. Annuloplasty was performed in 40% de Vega, and the other were segmental. They followed them up. The hospital mortality was 8%. The need for reoperation at 12 years is 50%. So there is actually a failure of this type of technique, the de Vega type. And if you look at the freedom from valve-related complications at 13 years, it's also low. The problem, obviously, with all the tricuspid valve surgery, there are always associated left-sided lesions. So the durability for repair for tricuspid valve is in question all the time, and as I said, it depends on also ventricular function, left-sided valves, and what you need to do for other valves. And more than often also, sometimes we end up operating on the mitral valve because of whatever reason, degeneration or endocarditis or paravalvular leak, and there is a moderate to severe lesion on the tricuspid valve, and we end up operating on them at the same time, and may not be indicated independently if we are looking at the tricuspid valve itself. So again, ring or suture, this is my preferred technique. Myself, I like the bicuspidization, which is quite simple, effective. This is from Larry Cohn from Boston, and they looked at the difference between ring and bicuspidization, and in that series they were equivalent in terms of actually, the survival was better in the bicuspidization, and the freedom from moderate or more tricuspid regurgitation was more with the ring procedure. I personally like this. It's fast, it's effective, and it doesn't add, and it's as good, in my hands at least, as compared to the ring annuloplasty. Now, looking at tricuspid valve annuloplasty with rings, does it improve long-term survival? This is a different view comparing de Vega with ring annuloplasty, and the use of annuloplasty ring was an independent predictor for long-term survival and event-free survival. Now, I believe that the de Vega is not a good operation for the tricuspid valve, and many times the suture fails, and it doesn't produce a long-term durability for tricuspid repair. And if you compare both the survival and the freedom from reoperation, they were better in this particular series in the ring compared to the de Vega repair. So after the repair, you get a recurrence of TR. And what do? The reoperation for the failed tricuspid valve is quite morbid. Looking at 74 reoperations following previous tricuspid repair, 92% required mitral or aortic valve surgery, so they become a big operation, so they most of the time with other surgeries. And their hospital mortality was, in this particular series, 35%. It's quite high, and it's substantial. Most of the time, it's either a second or a third. Sometimes it reaches up to 6th or 7th redo. My highest redo in valvular surgery was 6th redo. So the mortality can be substantial, and the survival also is abysmal at late follow-up. Now, also looking at the possibility of replacement. So now we do have issues with durability. We have issues with techniques. So should we replace every tricuspid valve we deal with? We do also have an issue with that particular point, because if we end up replacing, the replacement, at least historically, do carry a higher mortality compared to a repair. And this is a paper looking specifically at that. The overall 30-day mortality was for the repair 13%, and for the replacement was 33%. Now, this might be including a surgeon's bias, or the substrate was more sicker patients who ended up having a tricuspid valve replacement compared to a repair. Obviously, now with the introduction of valve-in-valve, this may change, because you may end up actually replacing more valves on the tricuspid side, hoping that you will have a valve-in-valve later on. But if you look at the survival of those patients who had tricuspid valve repair versus replacement, it is better at 25 years. That's 25 years follow-up, and it was statistically significant. And the freedom from reoperation for tricuspid valve repair versus replacement was better for patients with at late follow-up. Now, this paper looks specifically at propensity analysis, and we always talk about the possibility of bias introduced with the surgeons. This is a propensity match of 68 patients comparing, so they are matched with all the baseline criteria, and their operative mortality was similar between a repair and replacement, and their ICU stay was the same. Replacement had significantly longer hospital stay, and also at 1 and 5 years and 10 years survival was similar. So matching all, you may actually get the same results, and that's why I'm saying that there is always a surgeon's bias and a case bias that will interfere with this case series and may change the outlook on the survival and the benefits, late benefits of those patients, and this is their survival curve. So if you have to replace, which would you want to choose, a bioprosthetic or a mechanical valve for the tricuspid valve? It is better to put a bioprosthetic, because you can avoid anticoagulation, as well as the bioprosthesis generation is less in low pressures, so it actually survives better than the left-sided valves, and it means maintains the ability to intervene through the tricuspid valve. That is, if you need to do cardiac cath, or a patient needs a pacemaker or whatever later on in life. And this is specifically looking at the difference between bioprosthesis and mechanical valves. And when you look at their failure rate, the failure rate in mechanical valves in the tricuspid position was higher. But not only that, when they fail because of thrombosis. That means they come acutely, and also or they fail with pannus. The tissue valves, when they fail on the tricuspid, they would come more likely either with slow degeneration, or obviously they could come with endocarditis, both of which can be tackled very easily in surgery. Our experience, this is when we last reviewed them, and was ended in 2010, 133 patients. Majority of them were class 2 and above, functional class. The majority also have been a functional tricuspid regurgitation, and a whole group of other congenital and rheumatics, directly affected rheumatic. Organic was seen only in 7 patients, and the rest were all functional. Associated lesions, as you would always see in tricuspid valve series, they're always associated with tricuspid, with mitral and aortic and possibly bypass surgery. And those who've had a repair were 124. I would say the vast majority of these were a bicuspidization, except for those who've had an organic tricuspid valve. Obviously, they needed a specific tailored repair for those cases. Associated aortic surgery was in 33. Mitral surgery, replacement or repair, whether tissue or mechanical, and bypass surgery was another 20 patients. This is the majority of the repair was bicuspidization, but some of them have had different types based on their specific pathology and age. Sometimes when if the patient is young, I would tend not to use prosthetic materials. The hospital mortality was overall around 5%, and these were 2 in cardiac, 2 multi-organ failures. So they do sometimes represent these multivalvular cases, higher mortality than accepted, but it is acceptable for all those. And this is our follow-up. We've had only, in this particular series, during the follow-up period, severe or recurrent TR, around 7 of them, and only in the bicuspidization technique, only 1 of them have recurred. The others were in the different types of other repairs. So in conclusions, ladies and gentlemen, tricuspid valve regurgitation does affect survival. Tricuspid repair is preferable to replacement at this point, even though that there is a trend on replacing moderate valves now, but I still think we still will see different issues, and should be valve-in-valve should be only reserved for those patients who are really at extreme risk. Repair is feasible in most cases. Ring repair or bicuspidization may be similar, at least that's the way I read it, and that's what I practice. And if replacement is necessary, then a bioprosthesis is better than a mechanical valve. Thank you very much.